the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Good morning, Dr. Viens, and welcome back.
Hi, thanks for having me.
Dr. Viens is a board-certified, fellowship-trained orthopedic surgeon with specialty in foot and ankle. Today's episode focuses on athletic injuries of the ankle. Next on the list, high ankle sprains. High ankle sprains are not the most common thing, but usually when you see them, they have a BFF, a big fat foot, and a big fat ankle. How do you know it's a high ankle sprain versus a more severe lateral ligament injury? And can you please touch on how you manage it and when you can get the athlete back to sports?
They aren't as common, obviously, as lateral ankle sprains, but they definitely are not rare. My practice, I see them every week. And acutely, again, it just goes back to general orthopedic principles and anatomy. Where does the patient actually hurt? And do they hurt on the ATFL and the CFL down at the end of the fibula, or do they hurt more up the ankle and between the tibia and the fibula? And then maybe they hurt in both places, or maybe they hurt in the deltoid ligament also. Again, deltoid ligament over medially often does go along with at least severe high ankle sprains. You're going to be thinking about the deltoid too. Does a patient have pain up by their fibular head or neck near their knee? If you have somebody who has obvious high ankle sprain or syndesmosis injury on an x-ray where it's really wide, make sure you get x-rays of the whole tibia and fibula, because they might not even hurt that much but have a proximal fibular fracture. You're not going to be fixing that proximal fibular fracture, but that might explain why they hurt at their knee, or they have peroneal nerve symptoms, something like that. A syndesmosis, like severe syndesmosis injury, or one that's very obvious, now that is pretty rare. There's something called a log splitter injury, where the talus acts like a log splitter and just drives up between the tibia and the fibula. That's not common. It's certainly not common you're ever going to see that on an x-ray. I think I've seen it twice, and that's easy. But what we're really talking about is the injury that's hopefully not unstable, but might have subtle instability. And that's the hardest thing with the syndesmosis, is the subtle instability. There's no exam finding that's going to always find it. There's no x-ray finding that's always going to show you. Sometimes you won't see it unless you do an ankle scope, which, certainly is beyond the scope of the talk. But the point is that it's hard to diagnose. And if you aren't looking for it, you'll never diagnose it. Really looking where do they hurt is key. If you squeeze their leg, kind of the distal aspect of the ankle, but above the ankle, does it hurt in the ankle? By doing that, squeezing the tibia and the fibula together, you can kind of windshield wiper at the joint if the ligaments are injured and that cause pain. Or anterior to posterior instability of it. So you can put your fingers around the fibula and kind of stabilize the ankle with the other hand. And you, almost like doing a drawer test or something in the knee, you may be able to pull the fibula back and forth front to back. And that's often actually more commonly on the way that you're going to have the instability is on that kind of a test. Or sometimes you can take the talus, and this is pretty subtle, but you can stabilize the ankle and shift the talus medial lateral, and you can feel it sort of rattling around in there. It's not the same as a talar tilt, but that's another way to look at it. But oftentimes it's just the history and where do they hurt? Do they have a bunch of bruising between the tibia and fibula up the leg? It's going to be more a high ankle sprain, and high ankle sprain is going to take longer to heal. And in some patients it can take months with an S. It's not a quick one. Often you want to be avoiding rotation, so a tall boot usually can be pretty helpful for these patients. Again, they can weight bear. It's like ligament injuries. Weight bearing in a controlled fashion is good. It actually helps the healing. And then once it's sort of calmed down, and if you aren't worried about instability, the patient's doing better, then physical therapy and all those things that you would do for a lateral ankle sprain, you may be switching them over to like a lace-up ankle brace, that sort of thing. Not every high ankle sprain means you're out for months, but you definitely want to counsel patients that it might mean you're out for a lot longer. And those are the ones you really, I would argue, even normal ankle sprains, getting in to see someone that specializes in ankles is a good idea, but high ankle sprains even more so.
Anterior posterior drawer, the distal fibula, and the acute high ankle sprain. I don't know how much somebody's going to let me do that, but the compression of the leg that you were talking about, I do it with both hands, kind of both palms, and start kind of more proximal toward the knee and going down. And that seems to be very good at defining it.
Yep, it is. Another way you can do it is a cross leg. So you can sort of have them do a figure four almost and cross their leg, and that pressure of their fibula resting on their knee often make it hurt. Not specifically right where their knees hitting their leg, but more down into the in the ankle joint itself. But yeah, you're right. In an acute setting, oftentimes you won't be able to do that. But sometimes these patients will just come and they're just like, hey, my ankle's been bugging me for a while, and subtle instability of that joint is it's not rare. The more we understand about the syndesmosis, the more we're probably finding it.
Posterior tibialis tendonitis insufficiency. Do you recommend orthotics for the athlete for this problem?
Assuming that they're symptomatic, then I think inserts and orthoses are not a bad idea. The key is, are they symptomatic? Like, do their feet hurt? Okay, if their feet don't hurt but they're flat, it's fine. They used to tell patients, oh, you can't do this, you can't do that, you can't be in the military. Or over time, we've understood that a lot better, that flat feet in and of themselves isn't necessarily a problem. It can be just a normal variant. But patients that have a painful flat foot, yeah, arch supports can help. But the key is their foot flexible or not? If you have a patient who's got a coalition, meaning, a bony or fibrous connection between bones that limits their motion, and they've got a flat foot as a result of that. If you give them an insert that's trying to push up on their arch and give them an arch and is fairly rigid, it's often just going to make them feel worse, because that foot isn't going to have an arch no matter what you do. So it'd kind of be like standing there and pushing on the wall all day, and the wall is not going to move. So your hand's just going to hurt. Well, in this case, your foot's not going to move. So it's just going to hurt if you got something hard in your shoe pushing on it all the time. If you got a flexible flat foot, and when the patient's non-weight bearing, it looks like they've got a little bit of an arch and their foot has got normal ankle motion and all that sort of thing, or you have them do heel rises and their heels invert and their arch reconstitutes, then yeah, I think an arch support or orthoses are good. Now, whether they need to be custom or not sort of depends. I try whenever possible to avoid the custom arch supports because they can be expensive, and often insurance companies don't cover them, and often patients don't necessarily need it. I find that there's some good arch supports off the shelf that can be obtained, often from pretty good sporting goods store or running store. Often has good options. Along the same lines, sometimes patients don't even need a custom arch support. They just need the correct shoe, and a shoe that's built to accommodate their foot. So going to a place that has a lot of options and knows about people's feet and isn't going to just sell you whatever looks cool or whatever's new, but really what's the right shoe for your foot, can be just as useful or more useful than going and getting some arch supports. So that's sort of my take on it. And then no matter too, if one foot's different than the other, for example, if they've had an injury and one side's flat and the other one isn't, maybe that's somebody who custom arch supports, et cetera, might be useful. But often that's not really what you're going to be dealing with in the athlete. Not never, but often not so much the case.
Right. And I also found cleats. Runners, soccer players, cleats are made for stability. They're not really great for support.
Right.
And I see a lot of these things with people wearing cleats. So keep that in mind. Last topic, OCD lesions of the talus. Just wanted to talk to you a little bit about these because I see these not infrequently, but I do see them. How do you know if it's there? Let's say you get an x-ray, you don't see anything there, and they keep having pain, keep having pain. You have to image it, but sometimes you'll see them on the x-rays as well. But let's say you don't see it on the x-ray and you give them 6 weeks, rehab an ankle sprain, whatever, you're just not seeing it, and they still have pain clicking, similar findings. What do you do?
So a couple of things. One thing to point out, and I've had this sent to me several times from urgent cares, sometimes even people who know a decent amount about orthopedics, sending me a quote avulsion fracture from the talar dome. That can't happen because there is no ligaments that attach there. So if you see a chunk off of the talus on an X-ray, particularly like an AP X-ray, it's not an avulsion fracture. It's a fracture of your cartilage, and it's an OCD, an acute one, and that's something that you want to get in to see somebody sooner than later because you might even be able to primarily fix that. So that's definitely not a follow up in 6 weeks kind of a picture. Oh, this is an avulsion fracture. No, that's not. We're not talking about the lateral X-ray where you have a little chip off of the tailored head or neck down by the navicular bone. We're talking about a on an AP view, you see something that looks like it's popped off of the talus. That's something that's important to remember. There's no ligaments that attach to the talar dome. It's all cartilage. So if you see that, it's a cartilage injury and get it seen. Now, sometimes you'll see sort of a lucency on an x-ray in a patient who's had a chronic OCD, or if it's large enough and the piece of cartilage is knocked off, you can see that, and that can tip you off. But like you said, Sam, most of the time you won't see much on an x-ray. Now, in my practice, if patients have mechanical symptoms and we're like catching, locking, they're going to get an MRI much sooner than later. It's almost like a displaced meniscus tear or something like that, where if you have true mechanical symptoms that's real, often there's something in there that isn't going to go away. So getting the information sooner than later is helpful. But assuming that isn't the case and they just have tenderness in the joint and it's been 4 to 6 weeks after an ankle sprain, that's often when I will pull that trigger and get an MRI. If you know for sure there's a chondral injury, you could argue CT scan can be more helpful to see how much bone is there, how big the fragment is. But even then, some of us will end up getting a CT and an MRI. But that's not really for the listeners to really worry about. More the point is it can be complicated, but if you know there's a fracture, maybe a CT. But I would say in general, MRI is going to be more the modality of choice for looking at these.
Sure. So it's tender with a slight effusion and mechanical symptoms. Those are the main points that you're looking for.
Yeah.
And surgery typically better sooner rather than later if you can catch it soon enough. What about the last question on this topic? What about return to sports? Let's say somebody has a defect and you have to go stabilize it surgically. Are they out for the season, for a year? How long does it take them to get back?
Well, it depends. A lot of the times these patients are patients who have ankle instability, right?
Right?
So if you don't do something about their ankle instability, and you just deal with their cartilage, that's not good. And you're probably going to have recurrence, or it's probably not going to heal. And you're probably more talking about how big of a surgery did they need, were there perineals involved also, and things like that. And maybe it is 6 months, maybe it's a year. Usually with cartilage injuries, you're going to give it 6 months till you say, okay, it's not working, or before you're going to try a second line kind of treatment for it and something fancier surgically um, than what you did the first time. But it doesn't mean that everyone that has an OCD that's treated with surgery is out for 6 months. I've had some people get back to hiking pretty aggressively, at 3 months. But oftentimes with an OCD, if you're doing a cartilage stimulating sort of procedure or grafting or any of those sort of things, oftentimes you're going to have them non-weight bearing for a period of time, potentially 6 weeks, and then progressive weight bearing in a boot. And so there you're already at 2 months. So then you got to not only rehab them from the injury, but deal with the fact that they've been out for a long time and lost muscle tone, et cetera. So, I think 3 to 6 months to get back to sports is not a bad estimate. It sort of just depends on all that. Now, if a patient has a cartilage injury in a primarily non-weight bearing area of, say, like the distal tibia anteriorly, sometimes we won't even really try to get that to heal back. We'll even just debride it and kind of carve out the tibia and make a little notch in the tibia just to get it back to stable cartilage. And that patient I'm going to get going and moving really quickly because I'm not really trying to get cartilage to heal. I basically cut out the bone area that was involved and move on their way. Same thing as if they have like a non-weight bearing plaque of cartilage becomes a loose body and we take it out and we're not really doing a microfracture or something like that, that patient we're going to get moving likely right away and into physical therapy and almost physical therapy without restrictions. So, you know, kind of return to play as soon as tolerated. But that's more of a specialized situation that isn't usually what we're dealing with.
Well, great information on the ankle. Dr. Viens, thank you very much. I hope to get you back soon so we can talk some more about foot injuries in the athlete.
Thanks a lot, and look forward to talking again soon.
Absolutely. Great stuff. Thanks, Dr. Viens. Thank you for joining the orthoPAC podcast. Join us for our 21st annual meeting in Nashville, Tennessee, PAOS in the Music City, September the 6th to September the 10th, 2021 at the Omni Nashville Hotel. Check PAOS.org for details.